Hi, a very good afternoon to all the audience and also to our distinguished guest speaker. Welcome to Sport Emergency Webinar Series 2, which is organized by Sport Medicine's Unit, Faculty of Medicine, University of Malaya, together in collaborations with Malaysian Association of Sport Medicine and also Sport and Exercise Medicine Research and Education Unit by University of Malaya. So today we have three distinguished guest speakers and our moderator will be Dr. Ramani. Dr. Ramani is actually a senior sport physician from University Malaya Medical Center. I would like to pass the time to Dr. Ramani. Please welcome.
Okay, thank you, Dr. Aston. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. Thanks for spending time. It's not easy to spend weekend time listening to this kind of webinar. So as Dr. Aston has mentioned before, this is a series 2 of sports emergency webinar that organized by Malaysian Association of Sports Medicine, supported by Sport Medicine Unit University of Malaya and also the Sport and Exercise Medicine Research and Education Center University of Malaya. So today we're going to have, we'll be listening to three important topics in sports emergencies. The first speaker will be Dr. Apara, will be talking about on-field sports emergency. Second topic will be sudden cardiac death in athletes, will be presented by Dr. Rizmi Najmi. And the third one, muscle cramps during sport, will be presented by Miss Catherine. Before that, a little bit housekeeping announcement here. All of you will be muted to avoid interference. And this webinar can be seen through FB Live, Malaysian Association of Sport Medicine as well. And after this webinar, it will be recorded on YouTube as well. If you have any technical problems, please feel free to write in the Q&A into the chat box. And at the end of each session, after each speaker, we will open to Q&A session. If you have any burning questions, can write in the chat box as well. Other than that, at the end of this webinar, CPD point will be awarded and QR scan code will be projected soon. Okay, without any further delay, I would like to welcome Associate Professor Dr. Abdul Halim Mokhtar. He is a senior lecturer and consultant of sports medicine in University of Malaya and University of Malaya Medical Center. He's doing private practice in UMSC as well, University of Malaya Specialist Center. He is also currently the director of University of Malaya Sports Center as well. Without any further delay, I would like to welcome Prof. Halim for welcoming remarks.
Assalamualaikum and good afternoon, everyone. Thank you, dear MC, Dr. Ramani, for that introduction, that kind introduction. I would like to welcome all the participants today in this Sports Emergency Webinar, Series 2. From the Malaysian Association of Sports Medicine, we are encouraging all types of educational activities, as well as conference or knowledge sharing activities such as this. And we are proud that this time we can work with the Sports Medicine Unit, the Faculty of Medicine of University of Malaya, as well as the Sports and Exercise Research and Education Group, also from the University of Malaya. And the topic for this webinar is actually a very tantamount topic in the line of sports medicine, and it caters a wide variety of emergencies and would be an integral part in the knowledge of a sports physician as well as any sideline medical personnel when they cover games in particular, and sometimes just in the office setting, yet recognizing it early before this happens. I'm sure you will enjoy the presentations by our expert panelists, Dr. Apara today, who will be talking about emergencies in on field, and then sudden cardiac death by the consultant radiologist from UITM, Dr. Rizmi Najmi Khair, as well as muscle cramps during sports, which will be presented by an EXCO council member of the Malaysian Association of Sports Medicine, Ms. Catherine Chung, who's also a physiotherapist, a sports physiotherapist. So with that, I would like to announce the commencement, the official commencement of this webinar, Sports Emergency Series 2. Back to you, Dr. Ramai.
Okay, thank you, Prof. Halim, for the wonderful welcoming remarks just now. I hope everyone is clear regarding the objective of this sport emergency webinar. Okay, I think we can move to the first talk today. The topic will be on-field sports emergencies. Speaker is Dr. Aparajita Krishnan. She is a consultant sports physician in Hospital Sungai Buloh Sport Medicine Unit. She graduated with a master's in sports medicine from University of Malaya in 2008. She has been lucky enough to head the sports medicine unit in Sungai Buloh Hospital and to lead 4 other exceptionally talented sports physicians there as well. She is very passionate about disabled sports in Malaysia and is an international classifier for the intellectually impaired athletes in athletics. It's very interesting. She is a self-confessed mama bear for her 4 kids who she terms as mosquitoes. Okay, the next 1 hour is yours, Dr. Apara. Please welcome.
Thank you very much, Ramani. Just give me a minute to put in.
Dr. Apara, your voice is a bit soft.
Can you hear me now, Chong?
It's still a little bit too soft. Can you nearer to the mic?
Yep, coming. Okay, can you see my slides now?
Not.
Yes, can.
Yeah.
Yeah.
But put on slide.
The presentation
show.
view.
Yeah, presentation.
Yep.
Yeah.
1 second. It's right. Is this okay?
Yes. Okay. Good.
Can you, Ramani? Can you see the
Yes,
slides?
clear.
Yes.
Yeah, clear. Yeah.
Okay. So thank you. Okay, good. Thank you very much, Dr. Ramani, for that introduction. Good afternoon, everyone. Thank you for joining us in this webinar. Now, as you all know, as for who knows me and who do not know me, my name is Apara. I am the consultant sports physician in Jabatan Orthopedic and Traumatology in Sungai Buloh. And I was actually given this topic today because I feel that everybody knows that since I have had about 13 years of sports medicine experience, that's not saying that I'm old, but yes, I have had 13 years of sports experience. I have actually come to see about more than 20 sports emergencies occurring in games that I have covered. Now, it is only thanks to Prof. Halim and Prof. Naha and all the MOs in Sports Medicine University Malaya who have come through the course as well, that I have actually survived my 13 years of sports coverage. Before I start my talk, can I please give a shout out to Dr. Nurul Hashim, who is the gazetting officer with me, who actually helped me with my slides today. So let us start. Let me define a collapsed athlete first. It is whereby an athlete is unable to continue participating and is also unable to remove themselves under their own power from the race course or field due to such a failure. Now, it is not necessarily related to the level of consciousness, nor limited to a cardiovascular event. It also can include musculoskeletal injuries like fractures and cramps. Now, as you all know, my topic is for on-field sports emergencies. We actually, for this topic, it can be classified into traumatic and non-traumatic causes. Now, the traumatic causes, it basically constitutes concussion, neck injuries, and other like injuries. This will be taken by Dr. Nick Hazima next week. So I urge you all to please join in next week as well. I will be taking over the non-traumatic causes. And as you were all told as well, Dr. Rizmi, the speaker after me, will be taking over the cardiac causes. I will be talking about the non-cardiac causes, which basically constitute heat illness, exertion collapse, exercise-induced anaphylaxis, and exercise-induced bronchoconstriction. So, to start off, let me just say that the heat illness spectrum is actually a group of disorders ranging from the mild or the minor heat rash, heat cramps, to the major heat stroke. Now, heat stroke is defined classically as a core temperature of more than 40.5 degrees Celsius, accompanied by the central nervous system dysfunction. So if you can see, you will see that I'm just going to show you this, which is the clinical guidelines of management of heat-related illness. This was done in May 2016. So for heat edema, your clinical presentation is actually very mild. You have mild swelling of the feet and ankles. It does not progress towards the pretibial region. It usually resolves spontaneously by just elevating your legs. Compression stockings are also advised. Now, if you go on to heat cramps, I shall not actually spend a lot of time here because my next speaker, Miss Catherine, will be talking about this. So I shall actually leave that be now. But I do need Dr. Chong's help for putting up the poll. The first poll, please, Dr. Chong.
Can you see the poll?
Do you think I should ask the question if just in case anyone doesn't see it?
Yeah.
Okay, there is a question here. If you are a medical officer in a 42-kilometer marathon and a participant comes by and asks you for a paracetamol, would you give it to the participant? A, why not? B, no, absolutely not. And C, I'm not sure. What would be your answer? We have a resounding answer of 64% no, 21% yes, and a 15% unsure. So let me actually answer this by saying, please don't give paracetamol, because antipyretics like PCM and NSAIDs, basically they interrupt the change in the hypothalamic set point. Now, what happens is when you do that, early symptoms of heat stroke can be masked. Not only that, PCM can also exacerbate fulminant hepatitis secondary to heat stroke. So yes, I I'm very happy that 64% of you agree with us saying that please do not give PCM. So now let me go to heat stroke. Basically, heat stroke is a condition where the core body temperature goes up to more than 40 degrees Celsius. It is a failure of the thermoregulatory response. This failure basically causes the denaturing of protein and the disruption of cellular process. Now, with the disruption of this, increased permeability of the vascular endothelium occurs, and this activates a coagulation cascade, releasing cytokines. Now, by and by, when this occurs, if it continues to occur, it leads to rhabdomyolysis, DIVC, and myocardial injury. Now, poor prognostic signs of heat stroke basically include a rectal temperature of more than 42.2 degrees, prolonged hyperthermia, residual brain function of less residual brain function, acute renal failure, as well as coagulopathy with liver hepatocytes damage. Now, if we go on to, so let me just tell you a little bit of heat exhaustion now. Heat exhaustion is a milder variety. First, it actually will, the clinical signs would be ranging from headache, fatigue, weakness. The participant will still be sweating. They may actually have a low BP. They may actually be a little bit confused. This is basically caused by reduced fluid intake and an increase in heat exposure. Here you will find the temperature of the body around the range of 38 degrees Celsius. Now, in contrast, heat stroke is when you have the skin of the participant is actually dry and hot because there is an impairment of the thermoregulatory response. The body temperature, when noted by rectal temperature, will be more than 40.6 degrees. There will be an increase in pulse and respiratory rate, and usually the patient, the athlete will be hypotensive. If it goes on, the athlete can actually have seizures, delirium, and actually can go into a coma state. Now, an algorithm of management of a collapsed athlete would actually start off with finding out how is this athlete presenting, whether he is having a rhythm or not, as in a heart rhythm or not. Now, if they're still having a rhythm, you have to check whether there's a rectal temperature, as I already have explained. And if the temperature is about more than 40, you have to institute immediate cooling. I will continue this algorithm a bit later because I will be talking to you about the other areas of collapsed athlete as well. So now, when you have an athlete with a 40-degree temperature as well as significant CNS involvement, you have to follow the right side of management, the right side of the algorithm, which actually says that you have to address the ABCs, you have to initiate emergency medical services, you remove the patient from the heat, and you begin cooling. And if possible, after stabilizing him quickly, you send the athlete to the medical center as fast as possible. Dr. Chong, could I have the second poll, please?
Yeah, sure.
So the second poll, the question would be, what is the best way to lower core body temperature in an athlete with heat stroke? A, cooling fans. B, immersion of ice water at 2 degrees. C, water immersion at 26 degrees. Sorry, warm water immersion at 26 degrees. And my favorite, eating lots of ice cream. Thank you very much. We actually have a resounding 51% who say that the ice water immersion at 2 degrees would be chosen. 30% say cooling fans, 19% say warm water, and nobody actually said eating ice cream, which I'm very, very depressed about. But okay, let's tell you the answer then. Normally, if a person has heat stroke, we would actually start off with cooling fans. I'm not saying that that is the only way of cooling him, but this would be the most apt answer, because if you put a person in an ice bath of 2 degrees, the person will actually, they go into vasoconstriction, and then heat loss is very less in that condition. So that would not really be very helpful. Nor would putting a person in warm water, because that wouldn't actually reduce the temperature fast. So yes, the answer would actually be cooling fans, but also associated with a lot of water on them, a lot of ice packs on them. This, if you can see, you have a person lying in an ice bath, as well as Prof. Naha's favorite method of reducing heat temperature in an athlete, by spraying or pouring water at oncoming participants. So we have actually done about heat stroke. Now I'm going on to exertional collapse. This is known also as exercise-associated postural hypertension. It is very, very common in endurance athletes, especially like the ones in marathon, triathlon, and cycling athletes. These athletes actually collapse immediately after stopping the race at the finish line after a long duration of activity, such as an endurance race. This is basically because they have postural hypertension. Now, while they are running, the venous return basically is associated with muscle contractions, especially over the gastrocnemius. Now, when the athlete basically stops running or cycling, there is a sudden pooling of blood in the lower extremities. And because of the reduction in the venous return in the heart, it causes a subsequent reduction in preload. And this causes a reduction in stroke volume and then a collapse. Therefore, this usually we find this very commonly occurring at the finish line. So now in exertional collapse, your athlete will basically come with the clinical features of dizziness, headache, sweating. Sometimes the athlete will say that they're weak, they're wobbly, they're dizzy. BP will initially be low, but then if you actually elevate their legs, they keep them lying down with their legs elevated, you actually find that BP will pick up after a while. There will also be facial flushing. Now, when you have athletes like this, please institute quick management, find out, start on your DRABCDs. You lie the patient down supine, elevate the lower limbs above the heart level. You have to check their vital signs, monitor the athlete every 5 to 10 minutes. Recovery should take place after about 10 to 15 minutes of this of this position. Hydration sometimes is not really necessary. It actually you will have to see on case by case basis. Now, I would only discharge a person if they are clinically stable with no recurrent episodes of lightheadedness, no dizziness, no other complaints of hypotension. If the BP that is recorded becomes normalized, if they are able to ambulate without assistance, as well as they must be tolerating orally. These are my checklist to see whether the patient is well enough to be discharged from my medical tent. Now, if not, if the patient also persists in having complaints of a low BP even after 20 minutes of leg elevation, if the temperature is more than 40 degrees, if they're hypoglycemic, if they have muscle cramps, which are severe, and they are altered, and they have any altered consciousness, I would actually start on my IV fluids administration, and I will do the other necessary treatments to the specific conditions. Now, if you can see the picture on the right, I hope this is my right and your right. It is a girl with her eyes closed. If you can see that diamond that I've drawn, it is actually denoting an area of perioral pallor, which is common in patients with this condition, with the condition of exercise-associated postural hypotension. And the picture on the other side is how we actually would keep a patient with legs in the recovery position. So now, if I can go on further, if another condition which is alarming for a lot of medical covers, in medical covers, is a condition that we call exercise-induced bronchoconstriction. Now, basically, the definition is an acute airway narrowing, which is actually reversible and transient, occurring during or after exercise, that can be observed in patients who not only sometimes are chronic asthmatics, but sometimes they do not have asthma, but they still suddenly come with these complaints. Now, the risk factors are usually personal or family history of atopy, allergic rhinitis, cold weather spots, and indoor spots or spots requiring high ventilatory rates. Now, the triggers are usually cold air, allergens, pollutants, or intense exercise. Now, the pathophysiology of exercise-induced bronchoconstriction, I'm sorry, my pronunciation gets a little bit off sometimes. Anyway, the pathophysiology is basically when the hyperventilation occurs in exercise, it causes a loss of heat and drying of the airways. Now, this dehydration basically increases the intracellular osmolality. And what happens is this stimulates the release of inflammatory mediators like histamine, cytokines, leukotrienes, among others. And when these mediators come about, they actually, associated with the airway dehydration, cause an exaggerated response in the airway, causing exercise-induced bronchoconstriction. Now, if I can get my slide, yes. So your clinical features are actually, it goes with cough, wheezing, chest tightness. Some people actually come with history of shortness of breath. There will be poor performance, easy fatigability. They are induced usually after about 10 to 15 minutes of exercise, and the symptoms often dissipate when the activity stops. Now, management is usually treatment of symptoms. We give a short-acting bronchodilator. That is our initial management, and then we go on after that to see whether they get better or not. Prevention is usually by asking the patient to warm up before going for the activity, to wear a face mask or a scarf, basically, to prevent the cold air from drying the mucosal layers. Sometimes actually a dose of short-acting bronchodilators can be given before the exercise is done. But please, I would urge you all, if you have symptoms like this, please go to a sports physician, or in fact a physician, and do the proper testing to check it out before taking medication by yourself. So now, okay, that was a very short. Let me just go on to the next topic, which is hyponatremia. Now, this condition occurs usually in healthy endurance athletes during prolonged exercise, which usually is more than 4 hours, who actually consume large amount of water. There is a dilution of intra and extracellular matrix due to the ingestion of large volumes of water, and this causes a decrease in plasma sodium concentration. And when this happens, there is a resulting rapid influx of water into the brain and lungs, causing pulmonary edema, cerebral edema, and it can actually go on to actually comatose a patient. Now, the brain swelling and the increasing severe neurological responses, as I said, can culminate in death from the rupture of brainstem. Now, with hyponatremia, you have two pathophysiologies. You have one pathophysiology is the sodium deficit depletion because of the inadequate intake during the game, or the second pathology would be the fluid overload, which is dilution due to the excess fluid consumption. So, can drinking water cause death? Yes, because a normal person's sodium actually will come in between 135 to 145 milliequivalents per liter. Now, in this condition where you have a reduction of sodium, symptoms will occur when sodium concentration falls below 130 milliequivalents per liter. Now, the athlete will actually come with complaints of confusion. They will be they will be not restful. They will complain of fatigue. Sometimes they actually can complain of feeling weak. They can have convulsions. So this is a condition which you have to actually have a high level of suspicion. Now, if you can see this cartoon, you will see actually that in 2001, the Chicago Tribune actually printed up a cartoon strip, which actually this is called Peanuts, for those of you of my age who remember this cartoon. Well, Peanuts, actually you have Snoopy the dog here, and he looks at Woodstock, the little bird, actually getting injured. And what he does is he actually comes and tries to see what is wrong with Woodstock. And even without touching him, He says it's obviously a simple case of hyponatremia. He runs back and gets a pail of water, and all he says is he needs a little bit of water and a little bit of salt. So now I would actually say, well, this can be a way of treatment, but I would hesitate to actually sprinkle salt on athletes. It could be devastating for some. So can I have the third poll question, please, Dr. Aston? Dr. Chong?
Yeah. Can
Okay.
you see a poll?
Yes.
Okay.
Okay, the third question is, what is the correct treatment for minimally symptomatic exercise-induced hyponatremia? A, administration of normal saline at 200 cc's per hour for 24 hours. B, give a hypertonic, which is 3% saline intravenous 100 ml bolus. Wait for the individual to void. Or D, give Lasix, 80 mg. Thank you very much. We have a 54% answer of give a hypertonic saline infusion, while a 33% of normal saline at 200 cc's. Thank you. Let me just explain to you. Now, the treatment recommended would basically depend on the level of symptoms that the athlete exhibits at the time of presentation. For mild asymptomatic hyponatremia, we would only restrict fluids, observe, making sure that the patient is fine, taking his vital signs, and waiting for spontaneous diuresis. While if there is severe sodium depletion where it's less than 120 millimoles, may require the administration of hypertonic saline. So that was the answer. The administration of hypertonic saline in severe cases. Now, in never use diuretics to treat hyponatremia. You will actually have athletes who come and who will actually tell you, you know, doctor, my ring is very tight suddenly now, you know. While I'm running, I was drinking well, I have no problems, but I'm feeling, my fingers are feeling very tight. My ring, my watch is very tight. So these are basically some symptoms that you have to take account on. And you have to actually see whether they need some amount of treatment or not. Okay, so the next condition I'm going to talk about is exercise-induced anaphylaxis, which actually is defined as a life-threatening condition that involves the upper airway, which is associated with hypotension during or after a physical activity. The pathophysiology is really unknown, but there are two theories that have been offered. The first theory is basically that exercise will release endogenous endorphins, and these endorphins stimulate mast cell release. And due to this mast cell release, it causes allergic responses. Now, the second theory says that there is increased intestinal permeability during the exercise, and food allergens that are in there come into contact with the GI immune system, which stimulates the mast cell release and thereby creating an exacerbated anaphylaxis or an allergic response. Now, clinical features would come as mild as urticaria over the skin, itching, redness over the face, hands, and body, swollen lips, tongue, and periobital area. In the respiratory system, patients can actually come with the condition of shortness of breath or stridor. In cardiovascular, they will actually have low BP, and they actually can have syncope, while GIT symptoms may come as abdominal pain, vomiting, and severe cramps. Now, management, this is the only time I can say for certain that every sports physician will say, stop exercising. This is I think the one and only time we say that. And we will actually tell the person we will actually institute DRABC, which is your first line of management. You lie supine, you lift up the legs, you check whether the patient has a pulse, and go on with your resuscitation. Some people actually put also, if you find that this is exercise-induced anaphylaxis, if you think it is so, epinephrine is also treatment for this. You have to make sure you set a line so that the patient is suitably resuscitated. Now, in this entire topic, I have tried to give you a variety of conditions that you may actually come into contact if you actually cover games. But before you actually do cover a game, what you should need to know is before you decide, you have to know the risk that whichever sport you are covering. So each sport will have their specific risks, and this is actually there are lots of research into this, and there are a lot of papers published on the types of risk involved. I actually make sure that if I am covering a marathon, we do a recce of the entire route before the event. I am sure Prof. Halim will tell you that when he is the chief medical officer, he makes sure that we actually cover the route 3 to 4 times until we can actually say the route by heart. Some people actually dream about the route at night, and still, we still continue recceing. We know the dangerous areas upon that route. We anticipate what and where injuries can occur in specific routes. We have to practice with the first aiders involved, and we have to know what type of exit plan should be constituted in a case of emergency. Now, this is a plan of the evacuation strategy for an ambulance in one of the marathons that we did a couple of years back. In fact, Dr. Chong is the one that did this evacuation route. This is the evacuation route when he was the chief medical officer in Putrajaya Marathon. You can see his beautiful picture and drawing of tent A and tent B, and the way that the separate ambulance would have to take and the route they have to take to the hospital, where through this path of through the marathon when it was occurring. I wonder if Dr. Chong actually remembers this. Okay, so
yeah, I remember well. That was quite some time ago.
Yes, it was. But yes, I do still keep all your slides. So yes, this is one of yours. So let me just give you an example of the timeline which we would do for a basic, just before the marathon. We would basically check on, we would make sure that we were always 3 to 4 hours before the race was there. We would be there, all the medical the medical doctors and all the services were there 3 to 4 hours before the race. The CMO would actually give us a briefing to make sure that all were accounted and present. There would be a radio check 1 hour before the event, so that the chief medical officer would know that everyone was at their positions, like everyone was at, whoever that was supposed to be in the drinking station would be there, whoever was supposed to be in the medical tent was there. Starting times would be well known by everyone. We would have the stand down time, but in actual fact, the last 10 to stand down would only be when the last runner gets in. And this would never be around 3 a.m. It would usually be up to 4:30. I think the medical would be the last people giving the medals to the last, the last participants that come. We would actually be giving them the medals as well. So we would have actually, we would need for a medical event like Putrajaya Marathon with 12,000 athletes running, we would actually have medical personnel, physicians. We would have about 3 of us, sports medicine doctors. Our medical MOs from would actually help us then. We would have medical assistants. We would have also, we would have emergency doctors to take over the red zones. They would actually be there assisting us. Now, there would be a very obvious distinction of what are the tasks for each tent. So this would actually have to be completely explained to all your medical staff so that nothing untoward will happen on that day. So you basically have to know your specific role and responsibility as a CMO if you are there. If you are a CMO, you have to decide on everyone's strength. You have to know who is with you and what they do well. You will have to assign who is in the red zone, yellow zone, and green zone. You have to make sure you practice resuscitating a person. Give them scenarios that they will have to practice. Know your player's illness. This one, I can say that most of the time we don't find out, but hopefully if you are actually covering a tournament like a small badminton or basketball tournament, you actually know who your athletes are. That would be easier. Marathons like 42 kilometers, when you don't actually know the participants, it may be difficult, but it can be done. And a lot of praying helps. You have to anticipate what equipment to bring, which will actually be very useful for you. So now, in conclusion, every life-threatening athlete situation occurs, and this occurs in almost every sport. Always know who is in charge. Always know who is best trained for that particular incident. Always be prepared, be resourceful if unusual situations arise. And the most important, always have an exit plan. Thank you. That is the end of my talk. Thank you.
Okay, thank you, Dr. Apara, for the very lengthy and detailed explanation. I'm feeling like I'm attending a master program again. Okay, now we come into the Q&A session. There's a lot of questions thrown up here. If I read from this Q&A box from the Zoom, the first question is from Shi Ling Ting. If participants in sports event insist on taking paracetamol, but we are unable to dissuade otherwise, and if we counsel participants to stop the event, but still insist no, and requesting for paracetamol, how can we help the participant? You want to answer by one or all together?
I'm okay with answering one by one, actually, no problem.
Okay.
Do we have time for one by one?
Sure, we have another 15 minutes.
Oh, okay.
Okay.
So, the thing you must understand, okay, so I think it's Dr. Ting, I'm not sure, but I will just say Dr. Ting. If you are a chief medical officer, you are in charge. You have to realize that if you do something that is against your principles, it will be difficult for you to actually look yourself in the mirror if something happens, right? So I would actually tell the athlete, I'm really sorry. If you plan on taking this medication, I will actually take the bib number from the athlete, so that, and I will tell them, I said, you know what, I'm giving you this medication and I'm taking your bib number and I'm giving it to my liaison, and that liaison will tell the race coordinator. So when this happens, even if the person runs, she's considered disqualified. So you tell her that if you actually don't want to, you do not want to listen, then it's up to you. But if I give you this paracetamol, you will be disqualified from the run. So that is basically how I handle it. Yes, I have had many people coming up to me, cursing, and so lots of angry mob style participants. But so far, I have been lucky. I have actually told them no, I will not. And even if I do give them, I keep them there. I keep them there, let the race run. After 20 minutes, that's when I discharge them, so that they cannot actually join the game.
It's something like AOR, Dr. Aparah?
If you see, that's the thing. If they AOR, I already have their bib number. And I explain to them and I take their bib.
Yeah.
So if they AOR without their bib, they're still considered disqualified.
I think, okay, it's clear, Dr. Ting. Okay, can we move to next question from Alicia? Interesting during this pandemic situation. Can you explain further on the face mask for bronchoconstriction when doing exercise?
I'm sorry, I couldn't hear your question.
Can you explain further on the face mask for bronchoconstriction? Can you hear?
I
cannot hear.
You're breaking up. You're breaking up on me, actually.
Actually, we are putting up the slide.
Okay, let me.
Question number 2. Yeah.
Okay, I actually closed it. Just give me a second. Let me open the thing.
Okay.
Okay. Yes. 1 second. Alicia says, can you explain further on face mask for bronchoconstriction? Okay. Alicia, now, because of COVID, we are seeing a lot of theories occurring, saying that the mask is actually bad. The mask will cause a lot of difficulty in breathing. the mask is causes a lot of discomfort. But I am not a believer, if you can call that much, because it's more of, I feel that yes, a mask does disturb you a little bit, but if you consider, there was one research, if I'm not mistaken, they said that if you continuously wear your mask, the first 15 minutes, you actually find there is a reduced amount of ability to oxygenate. But if you continue with this, you acclimatize to that condition, and oxygenation becomes better after that. So I'm actually for that type of research, because anecdotally, when I wear the mask also, I feel that yes, I use the mask when I am exercising. I use the mask when I am I I do line dancing. I know it's difficult to imagine, but yes, I do it with the mask, and I do not find a lot of difference. I specifically do not find, I don't know about other people. So if you actually want to ask me about whether it actually further exacerbate bronchoconstriction, I really am not very, very certain about that. For me specifically, I can say I don't think so, but I would need to research on it. Maybe I can come back to this question again after a bit of research in a while.
Okay. All right. I think it's clear. The next question is, generally we know that lack of water during exercise will lead to dehydration. How about drinking too much of water, and how much ideally should we consume?
Okay, so that is basically a question which I thought I actually covered. Okay, no worries. Usually, yes, in Malaysia we have a very what do I say? A very obvious type of problem of when an athlete doesn't drink a lot of water, they go into dehydration, and as the slides before this showed you, they go into heat exhaustion, and then further on into heat stroke, and further on. But yes, if this person actually says, if they drink too much water, they actually go into this condition called hyponatremia, which I also explained. This is a condition where the athlete basically drinks water throughout the activity, and so the serum sodium level in the body starts getting diluted, and the normal serum level is about 130 to 145. Yeah, I said 130 to 145. And when it starts going lower, you start finding out that with this dilution, there is a lot of extracellular fluid buildup. The athlete basically will complain of tightness, as I said, tightness of the ring, tightness of his watch, saying that he has difficulty breathing. Sometimes, if you're very, you can actually if it's a prolonged time, you actually can hear crepitus in the lungs. You find that this is it actually poses a question whether it is caused by hyponatremia. You can actually do a lot of there are a few tests you can do to actually check it out whether it is hyponatremia. So that for me, I have, in my 13 years of being a sports physician covering games, I have seen two people who have had this problem. One of those actually I treated, just had tightness of all her rings and all that. So basically what I did was, you have to restrict their fluids at that point, making sure that they rest comfortably and they are well. Okay. Now, if they come with more symptoms like shortness of breath and crepitus and all that, then we institute further medical help. Like we actually we can assess them further, and then but I would suggest you have a very high index of suspicion, and as soon as possible send this patient to the hospital, to the nearest hospital, because the correction of sodium has to be done very rigidly, and it has to be monitored. Therefore, it is it is basically done in the hospital setup.
Okay, Doctor. Okay, yeah. I think yeah, it's clear. We can move to next question. Heat stroke can happen in night marathon or night exercise.
Okay. Yes. I was the initial 3-4 years of me being the CMO of Putrajaya Marathon. The marathon actually occurred in the afternoon, and I was covering quite okayly, having people with heat stroke, with having all sorts of things. Then what happens is somebody had a great idea of having this marathon at night, hoping that we wouldn't have heat stroke, and it would be a much more exciting marathon. So from then on, I think we had 3. That's probably, yeah. I had so many after that, and every marathon after that, even though it was night, we had even more people coming in with heat stroke. This is because if you see Putrajaya, it is a area where there is very few trees. So the heat that is in the afternoon, basically it keeps in the road, in the tar, the whole day. And then at night, with convection, I think it's convection if I'm not mistaken, it starts coming out. And when the participants run on that, they actually not only have to bear with the heat that they produce, but the heat that is bouncing off the tar, bouncing off the buildings. And so basically it gave them even more of a risk of getting heat stroke, if that is
okay, I think it's clear already. Okay, now we go to next question by Azwan or Dr. Azwan. This one, exercise induced bronchoconstriction and exercise induced asthma, is it the same? And how to test for the exercise induced bronchoconstriction, and also the role of Montelukast, the muscle stabilizer. Dr. Apara.
Thank you, Azwan. Okay, so exercise-induced bronchoconstriction and exercise-induced asthma is, for me, it is basically the two separate entities actually become, they become one, because the symptoms are about the same, you see, and the treatment is also the same. So I would actually say yes.
What tests can be done to confirm the diagnosis?
Okay, so what happens is, as I was saying, you actually have to you actually have to ask your patient whether, okay, let's say a person comes to you saying that he has exercise-induced asthma or exercise-induced bronchoconstriction. I'll be scared if my patient tells me he has exercise-induced bronchoconstriction, but still, if the athlete comes over and he complains like that, what I would do is I would actually go for history and I would do a thorough physical examination. Now, my history would basically ask for what are the symptoms that he has, what are the types of, like say, what are the things that they can actually say. Some of them will say that they have shortness of breath associated with bronchi. But then you also have to ask them about when does it occur, what actually exacerbates this. You can actually differentiate a lot of things with this history. So I would suggest that you need to have a very good history, and also secondary, your uh, your not only investigations, your examination would be important as well. So examination, I would actually send the patient for a spirometry to find out whether it is a restrictive or a constrictive course, which then I will actually check how further on it can help. And then when this person is having it, we will actually ask them, we will see whether it works on short-acting bronchodilator. This can actually be used, which it's used very effectively actually. I would actually keep them on this, and this is a prolonged diagnosis really, with this, and with further checking out on the medication and checking on his symptoms, I would have to continue. So that would be my diagnosis.
The mast cell stabilizer, any role in prevention?
Yes, there is a role as a mast cell stabilizer does have a role. I would put that as a second mode of treatment actually, after my trying to use a short acting first.
Actually, we have a lot more questions, but I think we are unable to answer all the questions on live now. We are running out of the time. Thank you, Dr. Apara, for very lengthy details explanation on fields emergencies. Can we give applause? Although we cannot hear all the applause, but can we give applause? Yeah. All right. Now we want to move to the next topic today. Very interesting topic: sudden cardiac death in sports. I think a few weeks back we had a case during the Malaysian Hockey League where one of the goalkeeper suddenly collapsed on field during the match, and the goalkeeper was lucky because he was attended by expertise and experienced ISN team. Then apparently the goalkeeper now currently under IJN follow-up. He was not known any medical illness before. As I read before, sudden cardiac death incidents, unfortunately, we don't have in Malaysia. Maybe Dr. Rizmi can explain further. What I read, it ranges, the ratio ranges between 1 to 40,000 to 1 to 100,000 of population that occurs a sudden cardiac death during sports. Okay, next speaker is Dr. Rizmi bin Najmi Khair. He is a lecturer and consultant cardiologist in UITM Mara Sungai Buloh, finishing masters in sports cardiology. Wow, sports cardiology. I don't think many in Malaysia that we can find this kind of expertise. Sports cardiology from St. George University of London, UK. He will be talking about sudden cardiac death. Okay, Dr. Rizmi, the next 1 hour is yours. Please
thank
welcome.
you. Assalamualaikum and good afternoon. Thank you very much for giving me this opportunity to share some of the knowledge that I've learned the last 2 years. I should have talked first because it's difficult to follow on from Dr. Apara's talk. Anyway, going to talk about sudden cardiac death in athletes. Unfortunately, it's a very, very, very big topic. I'll try to make it succinct and interesting as much as possible. I'm a consultant cardiologist at UITM Sungai Buloh. You can see there, that's my cath lab. That's where I do all my battles and war with coronary artery disease. But I also play rugby. I love rugby. I play for Asas Rugby Club, which is one of the team competing in the Malaysian Rugby League. This has then spurred me on to learn a bit more about sports cardiology. And it's an interesting field, and I feel that there's a lot of knowledge that we could share today. So the outline of my talk, I'm going to talk about a few things. Number one, background, definition, what is an athlete's heart, incident and causes of sudden cardiac death, symptoms, prevention planning, and some case examples. So everyone know the benefit of exercise. There's decreased risk of coronary artery disease, it lowers blood pressure, cholesterol weight, and increased insulin sensitivity, gives you bones and muscle strength, reduces cancer, especially breast cancer, improve mood, and reduces stress. So this study was one of the first study was done in UK on the benefits of exercise. They took bus drivers who just sits all day on a bus and just drive the bus. They compare them against the bus conductors. If you remember, before, bus conductors, they walk up and down the buses, and London had double-decker bus, so they walk down on the ground floor and up on the upper decks. They also looked at postmen who walks around the neighborhood, and also the post office clerks. So those who are active, you can see there had a lower coronary heart death compared to those who are inactive. So definition, what is an athlete? So I thought that I'm an athlete after finishing my 5 km run, but far from it. Athlete is one who participate in an organized team. They have systematic and usually intense training and places a high premium on excellence and achievement. A young athlete are those who are aged less than 35, and sudden cardiac death in this population is usually due to a variety of congenital heart diseases. Masters athlete are those who are more than 35 years old, and unfortunately, the most common cause of sudden cardiac death in this population is coronary heart disease. Recreational athletes, we have more and more recreational athletes coming up. With this MCO, a lot of people have taken up cycling. So these are generally people who participate for health and enjoyment purposes. Activity levels may still be vigorous, some as vigorous as competitive athletes, but we have this definition of recreational athletes, so the guidelines can easily differentiate between the two. My talk today would concentrate mostly on athletes. So what is sudden cardiac arrest? So it's an unexpected sudden arrest of presumed cardiac origin in adults of over 18 years of age. The arrest should have occurred within 24 hours after onset of any symptoms that could be interpreted as being cardiac in origin. So next, characteristic of an athlete's heart. So athlete, they go through vigorous training and intense physical training, and the heart naturally goes some physiological changes. They go through morphological changes where the heart becomes bigger, electrical changes where the heart rate may go down, and functional changes where the heart becomes more efficient. So you can see here, this is an example of a Malaysian athlete. I can't tell you his name, but you can see on the left side this is an example of an echocardiogram. You can see that the marker of 10 centimeters. Compare the non-athlete to an athlete heart. So the athlete has a much larger heart compared to that who is a non-athlete. And ECG changes. You've heard of people who are active and athlete, they have slow heart rate. The heart rate may even go down to 30 beats per minute. They get some funny ectopics, funny rhythms, and a lot of times I myself am confused whether this is a pathological or physiological changes. So in 2017, there has been a change in how to interpret athletes' ECG. Previously, there was the Seattle criteria, Bethesda criteria, but now the latest in 2017, they have got this international criteria for ECG interpretation in athletes. What is unique in this criteria is that they have included a lot of black athletes in their research. So you can see black athletes have got a myriad of ECG changes, which is different to Caucasian athletes. Unfortunately, in this international criteria, there wasn't a lot of Asian athletes, but some studies, some small studies have shown that Asian athletes, the heart changes is similar to Caucasian athletes rather than the black athletes. So my role in as a sports cardiologist is to differentiate between an athlete's heart or an athlete with a heart disease. They undergo similar, almost the same changes between the two. So it takes a lot of assessment to find out whether an athlete has a heart disease that can continue to compete, or they have a heart disease but they're allowed to compete safely. So incidence and causes of sudden cardiac death in athletes. It's very, very rare. It's just because we see athletes as someone that we try to emulate because they're very fit. We try to be as fit as them. They're very good looking. We try to be as good looking as them. Therefore, seeing an athlete collapse during an event or hearing news of their death at a young age due to sudden cardiac death is devastating. So incident of cardiac death, sudden cardiac death in general population, these are not just athletes, this is general population. You can see the lowest in this graph here is Japan, where they have 14 out of 100,000 sudden cardiac death in a year, in 1 year. Singapore, our neighbor, is quite close to it with 20,000 sudden cardiac death per 100,000. And that's in general population. 40, the lowest will be 14 to 20 per 100,000. But in athletes worldwide, sudden cardiac death in less than 35 years old is 0.7 to 3 per 100,000 athletes, which is much lower than the general population. There are many numbers, differing numbers. These are due to different methods of the sudden cardiac death being registered or being picked up. Some uses prospective mandatory reporting system. Some registry, like the US registry here, uses prospective mandatory system and also media and news reports. And you can see here in the US registry, they have 1 in 164,000 sudden cardiac death incidents, whereas in Italy, in the region of Veneto, if I'm not mistaken, they have prospective mandatory reporting system, and the incidence of sudden cardiac death is in the range of 1 every 40,000 athletes. Again, sudden cardiac death incident, different sports have got different incidents. Half and full marathon races, 0.5 per 100,000. US athletics, 1 every 50,000. Men's basketball, this is studied by Dresner. They have a high incidence of sudden cardiac death with 1 every 9,000 players. And different ethnicity too. We have black athletes. Black athletes in general have a higher risk of sudden cardiac death compared to Caucasian athletes. Unfortunately, I do not have numbers for Asian athletes at the moment. Would be something interesting to pick up. There's one study in 2007 by PPUM, the team in PPUM, where they look at sudden cardiac death in those that happened during sporting activities. You can see here they had a total of 44 deaths in that year, and most of them are above 40 years old. And you can see here the most common cause is ischemic heart disease or acute myocardial infarction. So what are the common cardiovascular conditions associated with sudden cardiac death in athletes? So best is to divide them into congenital or acquired. In a structurally abnormal heart, congenital causes could be your hypertrophic cardiomyopathy, your arrhythmogenic right ventricular cardiomyopathy, dilated cardiomyopathy, and many more, especially the valves. There's also congenital long QT syndrome and Wolff-Parkinson-White and Brugada syndrome. Acquired causes in an abnormal heart, the coronary artery disease, Kawasaki disease, myocarditis. In a structurally normal heart, commotio cordis, where you get punched in the chest just as in your heart, your T wave is peaking, and you get punched just at that time, which can cause you to get ventricular fibrillation. Other causes are drug-induced long QT syndrome or substances and environments such as hyponatremia. These incidents, again, they differ by country. It's just how the registry is done and how the data for the causes of death are picked up. You can see here the most common cause in the United States is hypertrophic cardiomyopathy. This is followed by idiopathic left ventricular hypertrophy and coronary artery anomaly. Whereas in Italy, the most common cause is arrhythmogenic right ventricular cardiomyopathy, followed by coronary artery abnormality. In the UK, again, very, very different. What they have is the largest group is sudden arrhythmic death syndrome. This is followed by idiopathic left ventricular hypertrophy, arrhythmogenic ventricular cardiomyopathy, and you can see the hypertrophic cardiomyopathy, which is the highest cause of sudden death in US, but in the UK only attributes to about 6% of sudden cardiac death. Sudden arrhythmic death syndrome is when is a diagnosis from autopsy. So this registry is from the team in St. George's, London. So they receive post-mortem heart from all over the UK, and this is examined by the pathologist there, Dr. Mary Shepherd. If they found nothing wrong with the heart, where the heart has a normal size, normal weight, no hypertrophy, no valvular disease, no coronary artery disease, they would generally put the death down as sudden arrhythmic death syndrome. So I can see that the most common cause of sudden cardiac death is sudden arrhythmic death syndrome. Next, symptoms. They usually do not complain of anything. That's why it's called sudden death, I guess. But some study have retrospectively asked family about if the patients or the victims have complained of anything. So there are complaints of palpitation, they're breathless more than usual, they get dizziness, syncope, deterioration in athletic performance, and chest pain. So how do we pick up on these athletes with sudden cardiac who are at risk of sudden cardiac death? Not easy, as number one, the incidence of sudden cardiac death in athletes is like I said, very low compared to the general population. So one of the ways of picking this up is by screening program. And also talk about medical facilities during sporting events and training, although Dr. Apara has spoken a lot on this. So screening program, its aim is to focus on common treatable condition. It has to be suitable and cost-effective tests and lead to an intervention that reduces complication of the condition. There's no point doing MRI on say 100 athletes where only one or less than one would be picked up as at risk of sudden cardiac death on MRI. Again, there are debates on whether echocardiogram is cost effective, whether ECG itself is cost effective. In the US, they advocate history, physical examination, and a 12-lead ECG, whereas in the UK, they do a targeted examination. They do physical examination, history, physical examination, ECG on everyone, and those who have some abnormalities only then are referred on to do an echocardiogram. So again, what are the pros of a screening program? It identifies athletes at risk. It may prevent sudden cardiac death. I'll elaborate more on may prevent sudden cardiac death. Understand the impact of sports on cardiac structure, and if testing is normal, reassure that risk is extremely low. The cons are we could find abnormality which has no clinical consequence. The athletes may have a small, say, biphasic T wave on the ECG, but he has no symptoms. He continues playing at an elite level. So what do we do with these types of athletes who have some abnormality which may have no clinical consequence? Number two is cost. An echocardiogram costs about 500 ringgit. Cardiac MRI costs about 6,000 ringgit. So a lot of people argue whether this amount of money should be spent on athletes, whereas the same amount could be spent on the general population and prevent deaths, which is more common. There's an immediate and long-term psychosocial impact on the athletes, and like I said, there's a large number of false positives. So this is a paper done by Anil Malhotra. He's the sports cardiologist in charge of Manchester United, and also by Prof. Sanjay Sharma, who is in charge of Tottenham Hotspur. So you can see here, they found that, so they had a database of about 11 years that they went through, computerized. When they first started the study, all this database was in a cabinet, all dusty and all that. And they had to go through each one, computerize each one, and they did a good job. They had 11,000 FA footballer that they went through and looked at the causes of sudden cardiac death. You can see here 35% of the cause of sudden cardiac death is from cardiac cause. Sudden death is by cardiac cause, about 30% from road traffic accident, 22% from cancer. They had almost 11,000 adolescent FA footballers that underwent screening. They found about 42 who had disorders associated with sudden cardiac death. Out of the 42 abnormals, 2 died from hypertrophic cardiomyopathy. If you look at the other arm, they had those who did not have any abnormality during evaluation. However, 6 of them died from cardiac-related causes. You can see one died from hypertrophic cardiomyopathy, 2 from arrhythmogenic right ventricular cardiomyopathy. So this fueled a lot of debate whether pre-participation screening is helpful in preventing sudden cardiac death. Here's another study. So they wanted to know the screening work. So this is looking at athletes in the Veneto region of Italy. So this is a prospective study where they look at athletes they started in the year 1980. And you can see that the incidence of sudden cardiac death is about 3.5 per every 100,000 person years. But as the program continues on, you can see the incidence just tailors down and tapers slowly to about 0.5 per 100,000 person years. So what this program has done is they have identified those who are at risk of sudden cardiac death, and these athletes are then disqualified from competition. So then the occurrence of sudden cardiac death has become lower. So it does show that screening work in identifying those athletes at risk. So we've done screening. We found someone who has some abnormality of the heart. What do you do next? So the question I always get is, can the athlete compete? It is not an easy question to answer. There's a lot of assessment that I have to go through, but my role is just to advise the athlete. I try to be an athlete advocate. Say 10 years ago, athlete with cardiac abnormality, they are automatically disqualified from competition. But as knowledge of this athletic heart has increased tremendously over the past years, we found that many of these athletes with heart condition, they can still compete. But it depends on a few things. So this is a simple idea of sports disciplines and its hemodynamic effect on the heart. You can see sports like archery, curling, golf, and motor racing. They do not have a lot of hemodynamic effect on the heart. Whereas endurance, you can see the heart rate goes up, blood pressure goes up, cardiac output goes up. In power disciplines such as rock climbing, alpine, weightlifting, and wrestling, the heart rate doesn't go up as much as endurance, but the blood pressure goes much higher than endurance sports. And most of the cardiac remodeling, where you see your right ventricular hypertrophy, your left ventricular hypertrophy, your ECG changes, they mostly occur in endurance athletes. So this is the role that I play. So those athletes who have abnormality found on pre-participant screening, they are sent to me. So what I do is take a detailed history, physical examination. The history includes family tree. It's good that if they have any of their relatives that comes with them, and we can get a more detailed history. There's 5 parameters at rest that I assess, including ECG. I do echocardiogram, even though some do not advocate doing echocardiogram, but I feel that echocardiogram is an important aspect of assessment, especially in Asian athletes, Malaysian athletes as well, because we do not have much data on them. So doing an echocardiogram just gives us a database on what abnormality that we may encounter in them. So I do assessment during exercise. I try to mimic the exercise that they do as much as possible. So say those who plays football, putting them on an exercise stress test where they run. I try to get in a normal exercise stress test, a Bruce protocol. The stages goes up every 3 minutes, stage 1, 2, 3, 4, all the way to stage 7 every 3 minutes. But say with footballers, I go from stage 1 straight to stage 4, because in football it involves slow jog and then sprinting. So I try to mimic that as much as possible. In my center, I also have a cycling ergometer. So like I said, most of this athletic heart occurs in endurance athletes. A lot of study has been done on cyclists. So I do have a cycle ergometry that I can use for cycling athletes there, or those who love cycling, just to see how much changes occurs in their heart. Number 4 is recommendation. Number 5 is follow-up. So this is a basic idea of how I do my assessment. So looking at after history, examination, ECG, I look at their echocardiogram, look at their ventricles, their pulmonary artery pressure, aorta, looking at ECG, arrhythmia during exercise testing, and saturation during exercise. So if they're all okay, they can go with any sports they want. Those who may have some abnormality, they may have some limitation in what sports they can enter. And as you can see, those who are more severe, no competitive sports at all, only skill sports. And when I say no competitive sports, does not mean they cannot exercise. They still are advised to follow the WHO guideline of exercising 150 minutes per week. It's just that there's no competitive sports, and the exercise is exercise for health rather than competition. So my advice to athletes after seeing them is very, very individualized. It's not one box fit all, one shirt fit all. Every athletes have different ability. They have different baseline fitness. What I try to be is be individualized, being practical and pragmatic. And these athletes, I cannot actually force them to stop competing. I'll tell them, I'll advise them, yes, you need to stop competition. Most of them do follow the advice, but those who I deem safe to compete, even they have some mild cardiac abnormality, they need regular assessment and continuous follow-up in a specialist center. Here, like I said, pre-participation screening may not pick up all athletes who are at risk of sudden cardiac death. So like Dr. Apara has mentioned before, the emergency service at medical facility, sporting event has to be addressed pretty importantly, because there needs to be planning and delivery of the service by multiple agency. They must provide life-saving intervention and transportation to definitive medical care, provide immediate minor treatments, and provide treatments and onward referral to medical specialties. I was involved in the London Marathon a few years ago with Professor Sanjay Sharma, who's the medical director for the marathon. As you can see here, these are the people who are involved in a sporting event. So not an easy job, Dr. Apara. Well done. Even FIFA have 11 steps to prevent sudden cardiac death in football. Step 1 is prevention, all the way to step 3. Step 4 is planning emergency protocol, training equipment, and all the way to step 11, where all these steps, an AED is of utmost importance, training of staff in basic life support. And this is an example of the FIFA bag. You can see there the AED takes precedence, and there are a lot of other equipments there as well. After planning all that, there are still things that we may miss. This was a situation I was in years ago. Played rugby. There's a player who was injured in the game, and we had everything ready except for access for the ambulance to get on the field. This is a car that was parked in front of the gates into the field. You can see the ambulance trying to get in. The players, both teams, they were helpful and moved the car to the side just to get the ambulance through. So meticulous planning, not just on the field, but around the field as well. Here, I'm going to show you what happened in a few years ago. One is an Africa Cup with Mark Vivian Foe. The other one is in the English Premier League with Fabrice Mwamba. The timer is about the same. The patient, Fabrice Mwamba collapsed and Mark William Four collapsed around the same time. I can see medical team getting there. In Mark Vivian Four's situation, there were a lot of slapping done. The medical team was there, but there was a lot of slapping. The coach was not sure what to do. He was more concerned about substitution, I think, at that time. While you look at on the left side with Fabrice Mwamba, medical team is there. They've got the assessment done. They've got an AED by the side. Here they are starting CPR at, they haven't started CPR yet, but they've got all the equipments by the side. So about 1 minute in, around here, so they've started CPR. Everyone knows their role, what they should be doing. No one is getting in the way of the medical emergency team. Can see equipments are all on. Everyone's ready to do their role, and one of them is taking out the AED device, and while one is administering CPR, can see there the pads of AED coming out. The CPR is stopped temporarily for the pads to go onto the body and then recommence. This happens just a few seconds only of stopping CPR. It's a very difficult situation to be in. It's not perfect. It's on the field. Even in hospital, I handle hospital cardiac arrest. It is not easy. And doing it on the field with very minimal emergency device is not easy. Can see that the AD is now analyzing rhythm. Everyone knows what to do. And after about 2 minutes, the first shock is given. So you can see two very different outcomes. Fabrice Mwamba, time from collapse to CPR is about a bit more than 1 minute. And time from collapse to first shock is 2 minutes, 21 seconds. So two very different outcomes. So let's go on to cases. I've got two interesting cases. One which I took from my studies when I was overseas, and one here in Malaysia. So background, 15 years old male, a European Academy footballer. He underwent pre-participation screening in 2003. Completely asymptomatic, playing at a high level as a 15 years old with normal physical examination. This was his ECG. You can see there in leads, especially V4, V5, V6, there's some T inversion and high R wave, which means LVH with strain pattern. So he does have history of hypertrophic cardiomyopathy. His father has history of apical hypertrophic cardiomyopathy, but there is no family history of sudden cardiac death. He had an echocardiogram which shows left ventricular ECG with LVH criteria. Echocardiogram showed apical hypertrophy of about 15 millimeters. He even had a cardiac MRI which shows apical hypertrophy but no fibrosis or scars. Holter showed no arrhythmia, so he was labeled as low risk apical HOCM and he was allowed to compete. He even played in the Champions League. He remained under this St. George's Centre's follow-up. He remained completely asymptomatic for 15 years. He comes back from annual review. But in 2018, he became aware of a strong heartbeat. He was injured at that time. He was very stressed. So he became aware of a palpitation, a strong heartbeat. We did an ECG, which was essentially the same as before, was the same as ECG when it was in 2003. Echocardiogram was about the same. Normal left ventricular function, mild left ventricular wall hypertrophy, no outflow tract obstruction, peak LV wall thickness of 15 millimeters. Normal LV wall thickness is about 13 millimeters and below. With the exercise testing, this is where we found something abnormal. He had a normal blood pressure and heart rate response, but there was some ectopics, some isolated ventricular ectopics during exercise, and during recovery there were 2 couplets. So went on to perform a Holter test, 48-hour test, which shows a lot of non-sustained ventricular tachycardia. It's about 500, more than 500 in 24 hours. He had an MRI, so it was a normal size. There is hypertrophy at the apex, but seems to be the same. However, this time there was extensive scar over the left ventricle, the apical left ventricle, and circumferential subendocardial late gadolinium enhancement. So these 2 are new compared to 2003. So in summary, here's a disease progression where in 2003, he had no ectopics on stress testing and Holter, but he developed more than 500 ectopics in 2018 after 15 years. We have this HCM, hypertrophic cardiomyopathy risk of sudden cardiac death calculator. Here you can see the score went up only slightly from 1.75 to 1.8. So anything less than 4 has a low risk of sudden cardiac death. But what we're dealing here is not a normal person, not person for normal population. You can see in the hypertrophic cardiomyopathy risk calculator, I've highlighted it in orange. So it should not be used in elite athletes or individuals with some other disease like as Anderson-Fabry and Noonan syndrome. So there's no validated score for athletes. However, we use this as a general calculator to look at sudden cardiac death risk. We then discuss with the patient about their risk. You can see here there is progression of the disease, but the risk score has not increased. His symptoms is only of a strong heartbeat. He can still play at the top level. So that was the question that he asked, can he compete and play? So we think he has a low ESC risk score. He's an adult age. And we had an understanding between him that if he feels unwell, it is time to stop playing, but he can continue to play safely. The medical doctor has been informed about his condition and they have all the appropriate equipments ready at the pitch side. So in summary, 32-year-old elite professional footballer with apical hypertrophic cardiomyopathy. He has new findings of ventricular ectopy and extensive cardiac fibrosis, a stable 5 years risk of sudden cardiac death. However, there's a worsening arrhythmic substrate. He is still playing at an elite level. However, he is under close monitoring. He has ambulatory ECG monitoring every 6 months, yearly echocardiogram exercise test, and 3 yearly cardiac MRI. So if we found that it does get worse, so we would advise him to stop playing at competitive level. So second case is a 19-year-old Malaysian plays football at a national level, completely asymptomatic. However, during pre-participation screening, he was found to have an abnormal ECG. So this is his ECG. You can see that it could be that he has a large ventricle. He has sinus bradycardia. He has a large ventricle. There's some early repolarization. If you look at leads V2, V3, V4, V5, the J wave where the QRS meets the T wave is elevated. If you have not seen this ECG before and it was just given to you in the emergency department, some people would interpret this as ECG of someone who has a myocardial infarction or heart attack. But this was his ECG at rest. Is this normal or not? If you look at the international criteria for athletes ECG, you can see he fulfills the normal ECG finding. He has sinus bradycardia. He has some ectopic atrial conduction. He has early localization of the ST segment elevation. So I would deem him to have to not need any further evaluation. But going back, he's only 19 years old. I would expect to see this type of ECG on a professional player who's been playing long term for at least 3 or 4 years. A 19-year-old with a professional footballer ECG, it can happen, but it is quite rare. So taking this into context, I did a few more tests. He had an extra stress test. He had an appropriate blood pressure and heart response. There was no arrhythmia at all, no ectopics. Is this still considered normal? I am not sure at this juncture. So we did an echocardiogram. Can see echocardiogram, he has a good ejection fraction, about 60%, no regional wall motion abnormality. But if you look at the bottom left-hand corner of the echocardiogram, can see I've labeled the right ventricle and the right atrium. So our left ventricle is usually much bigger than the right ventricle. So the right ventricle is probably about 1/3 of the left ventricle size. But here you can see clearly the right ventricle, the right atrium is the same size as the left ventricle, which is not normal. Well, it's not abnormal. It can be found in athletes who have trained for years and years as a professional. But again, taken into context, this is a 19-year-old footballer who has not turned professional yet. So I did an MRI. So the MRI was very reassuring. So he had a normal left ventricular size with ejection fraction of 55%. There was an enlarged right ventricle and right atrium. However, there was no scars and no fibrosis. So the conclusion was, this is someone with an athletic heart. So you can see the dilemma there. Even though the ECG would clear him as a normal athletic heart, but you have to take things into context. He's only 19 years old. To develop a professional athletic heart at a 19-year-old is possible, but it is rare. It's mostly seen when that person has been a professional for 3-4 years. I would expect those changes in someone who's 23, 24, 25, in a 19-year-old. I suspect there may be something wrong. All the tests were reassuring and it were all normal. So we diagnosed him as an athletic heart, no problem, safe to train and compete. But he is planned for yearly ECG and echocardiogram. Hopefully he'll be as great as the great Ronaldo, the Brazilian Ronaldo. So practical recommendation from these two cases. After the evaluation, the team doctor should be made aware of the increased risk of sudden cardiac death. Medical personnel should be trained in appropriate and suitable CPR. The team must have an emergency response plan. An AED or defibrillator device should be made readily available. In the gym that I go to in the curve, I go to Fitness First at the curve. The nearest defibrillator is in front of in the middle of the curve, which so anything happens, someone has to run about 100 meters to get it. So not ideal. Athletes should be advised on good hydration and refrain from competing in extreme environmental condition. Avoid performance enhancing substances, including large doses of caffeine tablets. So in summary, sudden cardiac death associated with athletic activity is rare but devastating. Victims can be young and apparently healthy, and while many of these deaths are unexplained, a substantial number have an underlying undiagnosed cardiovascular disease. And the majority of sudden cardiac death events in athletes are due to malignant arrhythmias. The potential etiologies of sudden cardiac death include structural heart diseases, inherited arrhythmia syndrome, and coronary heart disease, especially in those who are more than 35 years old. But the exact distribution varies according to age and geography. So when I discuss with the athletes about the findings from all this assessment and evaluation, we have to find the balance between the risk and benefit of athletic activity, and this depends upon several factors like baseline fitness levels, intensity and nature of athletic activity, and present extent of cardiac disease. Thank you very much.
Okay, thank you, Dr. Rizmi, for the very interesting, wonderful, and very detailed explanation about SCD. We know that knowledge and training is very, very important in handling the sudden cardiac arrest or death during the sports. Okay, now we have arrived to Q&A session. I can see few questions here. Let me read the first question from Ismail. Are all ectopics in ECG among athletes pathologic and rule out abnormalities? Can they be considered as normal?
Again, we don't just look at the ECG. You have to have a detailed history, especially family history and examination. One ectopic, say one PVC, is considered normal, but 2 or more ectopics in a 12-lead ECG, as you can see from the international criteria, is considered abnormal and they require further assessment. But again, history examination. If the history examination, especially family history, there's a history of sudden cardiac death, one ectopic is considered abnormal. But if they have none of those, one can be considered normal, whereas 2 or more is considered abnormal.
What the most common ECG changes in juvenile, Dr. Rizmi?
In juvenile athletes, in the UK, so I've seen a lot in the UK where they mimic Brugada syndrome. So the ECG lead placement has to be adjusted. So the normal ECG placement, the V1 and V2 leads are placed at the 4th intercostal space. So those ECG that mimic Brugada, so the ECG leads, the V1, V2 are placed above, a bit higher at V2, at the 2nd intercostal space, and also the 1st intercostal space. A few years ago, I had the opportunity to do some screening at the Gambang Sports Academy. We did ECG on all the students there. I'm happy to report there were no abnormal ECG findings like the ones that I found in the Caucasian juvenile athletes, but the most common ones are Brugada-like pattern. So you do have to adjust your ECG leads. But juvenile athletes, it's difficult because most of the studies are done on those who are more than 16 years old. So less than 16 years old, to say they're abnormal or not may be too early because the heart is still developing. The heart hasn't sit down nicely in the left precordium. So that's why they get all this juvenile Brugada-like pattern.
Okay, next question from Sharifa. What is the death rate SCD related to drugs, performance enhancer or steroids?
I don't know.
Yeah.
I don't think a lot of people would tell that they take performance enhancing drugs or steroids? My answer is no. If anyone else has the answer, they are more than welcome to answer for me.
Mm-hmm. Okay, from Sharifah as well. How do we manage exercise-induced hypertension in young athletes, and what risks of them developing cardiac events?
This is an interesting question. Yes. So in those, as we know, when we exercise, our heart rate goes up, our blood pressure goes up. So what I do is assess them on a treadmill, see how much the blood pressure goes up. Normally, if the baseline blood pressure is well controlled, the blood pressure response during exercise would be like a normal person. If they have to take antihypertensive drugs, so be it, they do have to take it, but I avoid drugs such as beta blockers or diuretics. I prefer giving them ACE inhibitors like perindopril or the angiotensin receptor blockers. Those who have hypertension, I assess them, make sure their baseline blood pressure is well controlled, and then once that is well controlled, I put them on the treadmill, see if their response during exercise is also controlled. I pick drugs, I avoid beta blockers and diuretics.
Next question, Dr. Razmi. Role of omega-3 in cardiac screening.
I do not know. In general, omega-3 does help in reducing cholesterol about 10 to 15% in the general population. But role in cardiac screening for these athletes, I am not sure. I'm sorry.
What about, okay, next question from Aizat. I think this is the last question that we can answer. Non-competitive athletes with myocardial bridging, any contraindication for them to be active?
No. So myocardial bridging, imagine our cardiac vessel, our left atrial descending artery, right coronary artery, left circumflex, they're all epicardial, meaning they are outside the heart, on top of the heart. But sometimes this vessel can go inside the heart muscle and come out again. So during contraction of the heart, this blood vessel gets blocked, and some of them may get chest pain. But these are benign condition. Unfortunately for them, if the chest pain is not tolerable, I would advise them to slow down. Some would need beta blockers to slow down the heart rate. It's a benign condition. It does not lead to sudden cardiac death. It may cause symptoms of chest pain at extreme heart rates, but in general, it does not cause cardiac death.
Okay, I think that everybody is clear with the question and answer just now. We apology that we cannot go through all the questions and answer them online now, but you can still communicate in the chat box or Facebook later on after this. Now we have arrived to thank you again, Dr. Rizmi, for the time spent here. Very important topic that should be highlighted by all the sports community, especially in Malaysia. Okay, now we have arrived to our last topic. Our speaker is Catherine or Chung Kian Ji, will be talking about muscle cramp during sports. She is a senior sports physiotherapist at PAU Physiotherapy. I assume it's a correct pronunciation, yeah? PAU PAU Physiotherapy in Desa Sri Hartamas, Kuala Lumpur. She graduated with a Masters of Advanced Clinical Sports Physiotherapy from Australia and has clinical experience in Singapore and Australia prior to returning to KL. She has provided sports physiotherapy coverage for professional and national athletes from multiple countries. She was a traveling sports physiotherapist for Asian Tour Golf prior to COVID-19 pandemic. Okay, the next 45 minutes to 1 hour is yours, Catherine. Please welcome.
Okay. Thank you, Doctor. So the title given to me was actually muscle cramps during sports, but I'm actually going to title it differently. So I'll be sharing mostly on exercise-associated muscle cramps.
Sorry, Catherine, can you speak louder?
Yep, can you hear me now?
Yeah, better. Thank you.
Okay, yeah, so I'm standing just a bit closer now. Okay, yeah, so I was saying that the title given to me was actually muscle cramps during sports, but I will muscle cramps and other types of cramps that we have. Sorry, it's not sharing. Okay. Ooh. Let me just reshare again. Yeah, sorry, it's not working. I'm not sure why. So these are some of my qualifications. So I graduated from UKM and then I went to Australia for my sports physiotherapy masters. I'm also an ACSM certified clinical exercise physiologist. Yes, so PAL physiotherapy is the correct pronunciation because that's the it's a family name. Okay. So what I'll be sharing on it's actually three major parts. One is exercise associated muscle cramps versus other medical condition. The next thing I'll be talking on is actually on the management. And then the third thing is some case studies based on my experience. I'm a sports physiotherapist. So what gets me excited is actually being outdoors where the action is. So I'll be sharing with you some of the experience I've had in sports events. So muscle cramps, it's quite common during sports. The definition of muscle cramps actually is just painful involuntary contraction of muscle or muscles. So it can happen to one part or it can happen to a few muscles. So muscle cramps can actually occur because of different or a combination of medical condition, or it can actually be non-medical related. So things like your genetic causes, muscular diseases, endocrine and metabolic diseases, electrolyte imbalances, vascular diseases, or even if you take pharmacological agents such as medication and whatnot, that can actually cause muscle cramps. So this is an extensive list, but non-exhaustive list of different causes of cramps. And this is also, the list continues from here. But what I would like to bring your attention to, it's actually more of this. So these are some of the diseases that may actually cause cramping during exercise itself, which is your diabetes, hypothyroidism, your vascular disorders, metabolic myopathy or radicular neuropathy, sometimes due to deficit in magnesium and some drug usage as well. But the focus that I will be doing on talk today is actually more of exercise-associated muscle cramps. So EAMC, exercise-associated muscle cramps, is actually a syndrome of involuntary painful skeletal muscle spasm, which usually happens during or immediately after an exercise, usually after an intense exercise or prolonged exercise. What you need to note about EAMC is that it is usually localized muscle cramps. So let's say if you go for a marathon or a prolonged soccer event, towards the end of it, that's when you start noticing a lot of runners or even players start to have cramps, especially on the calf. So that is more likely to be an EAMC unless it's some other medical condition that I will go through later on. So EAMC, like what I said, it's actually localized and it usually happens on muscles that you use repetitively during the sports event. And it usually happens on the calf, hamstring, quadriceps. So with EAMC, usually the intensity and duration of cramps generally it varies, but usually it goes away within like a few seconds to up to a minute, but it can still be painful. Some of them say that it resolves spontaneously, but sometimes it may last for a long time. The thing about EAMC is that it is usually not dangerous, but if it keeps happening, if the recurrent cramps keep happening, then the pain may persist for hours or days, and actually it inhibits them from training. And if you're an athlete, that is career ending. Yeah, if it keeps happening, it's potentially a premature end to an athlete's career. And that's when, as the medical professionals, we need to step in to find out what are some of the causes so that we can actually help to reduce this. So with relation to EAMC, there's something called cramp-prone state as well. So up to 8 hours post-exercise, there's an increased susceptibility to EAMC. So sometimes if an athlete were to exercise in quite intensively in the morning or in the afternoon, later part when they take a nap or their sleep at night, that's when they may notice more cramps as well. That's because they are fatigued. So the etiology of EAMC. So 50 years ago, we used to believe that it's actually due to altered serum electrolytes, which means that it's just electrolytes imbalances or an environmental factor. But in the recent maybe 20 years, research actually shows that it's actually more of muscle fatigue, which is altered neuromuscular control being the cause of EAMC. But until now, there's actually no, it's not exactly proven. This is what we believe currently, but it's not exactly proven just yet. I will be telling you why there is limitation and difficulty to conduct research on EAMC. So we'll just go through some of this altered serum electrolyte theory. So what was believed to be the cause of EAMC was that when somebody exercised intensively, there is fluid and electrolyte depletion, which causes desensitization of some nerve endings, and then this puts more mechanical pressure on the nerve ending, and that may cause EAMC. And it was also believed that exercise in hot and humid condition may actually increase fluid and electrolyte loss, and that may actually facilitate cramps. So this second sentence is actually true, but it's not necessarily the cause of EAMC. So another proponent, what you need to know is that most of the research that supported this altered serum electrolyte theory was actually based on researches done in 1920s and 1930s. And even then, the research were mostly on miners, ship and construction workers, which actually developed cramps because of hot and humid conditions. So that is when the researchers back then said that the majority of the cramps occurred in hot months, and they suggested that saline drinks and salt tablets will reduce cramps. But you have to note that because it was done in 1920s and 1930s, I do not have access to the full article. And it is also in level 4 and level 5. So if you can imagine, it's like almost 80 to 90 years ago. I would say that probably the research quality isn't that good, but it's a start. Yeah. So this theory was debunked because, like what I said earlier on, the altered serum electrolyte theory doesn't necessarily explain EAMC, especially athletes who exercise in colder or like indoors environment where it can actually be 10 to 12 degrees. So with this theory, it doesn't really necessarily explain that because EAMC can still happen in cold places. So what I want you to note is that if there is truly an altered serum electrolyte concentration, then the muscle cramping should be more generalized, rather than in EAMC, it is more localized, and usually it happens in muscles that are heavily involved in the exercise itself. So one is more generalized and one is more, so that's EAMC. So what you also need to know is that because cramps are so unpredictable, it's so difficult to actually lab studies, what usually you'll put electrical stimulation on an animal. If you stimulate the muscles based on electrical stimulation, it is quite different. It may actually induce cramps in some. Quite such on effect frequency required to initiate cramp.
There's some interference. Catherine, can you check back your network?
Yeah.
Yeah.
Okay. Here. Is it?
Is not smooth.
Okay, let me stop sharing and then I'll share that again, okay?
Yeah,
Okay.
yeah, sure.
Is it clearer now? Can you hear me?
Yeah,
It's
we can
better.
hear.
Better. Okay.
Okay. So yeah, so the next thing is on the environmental theory. So we believe that exercising in hot condition and which also leads to subsequent loss of fluid and electrolytes will cause EAMC. So what I'd like to say is that hot conditions, hot, humid, will definitely lead to electrolyte and loss of water, but it may not necessarily lead to EAMC. It may actually cause more of heat cramps and whatnot, but it may not necessarily explain EAMC as well. Sorry, there is a hang again. Let me just stop share and then I'll do that again, okay? I'm not sure why. Is this okay now? Yeah, it's working on my side. Is that okay?
Yes, it's okay.
Yeah. So coming back to this, so the opponents for environmental theory is that it said that EAMC is actually not directly related to the increased core temperature. So let's say if you go to a sauna where it's hot, does that mean that you will definitely get muscle cramps? So that may not necessarily be true. So research also shows that at rest, passive heating like sauna doesn't result in muscle cramping, and cooling doesn't necessarily relieve it too. So this is what the later research and whatnot and the medical journals actually suggest. So the etiology of EAMC would be when there's repetitive muscle exercise. What happens then is that there are other contributing factors to muscle fatigue. There will be things like because of a sudden increase in exercise intensity or duration, or environmental condition, or if the person is not fit or some disposition, it may cause muscle fatigue. So with muscle fatigue, what happens then is that there's an increased excitatory efferent activity and also a reduction in inhibitory efferent activity. So all this leads to your altered neuromuscular control, which also increases your alpha motor neuron activity, and that actually leads to muscle cramp. So what I would like to pinpoint here is actually more of muscle fatigue. So this is also another article that talks about premature fatigue as the cause of EAMC. And what you need to focus more on is actually on the activation of muscle in shortened length. So it happens more in concentric rather than eccentric. So if your muscles fatigue a bit earlier, prematurely, that's when cramps like EAMC may happen. So epidemiology of EAMC, it really depends on which journal you get. And it happens more in long distance running, endurance sports in general. It also happens in sport. So generally, minor income, it's
The network is back again, Catherine. Yeah.
that would be AMC.
Can't hear you, Catherine. Okay, you can restart back.
Okay. Let me just switch to my
Catherine, are you there? Catherine, are you there?
you
Okay, probably I can share the slide for on behalf of you. Is that possible?
you you see me? Like, can you see the slides?
I cannot. It's lagging. Okay, we have some issue with Miss Catherine's connections. Am I? While she is connecting back to continue the talks, we might actually this might actually take a while. Okay, so probably I can actually show the QR codes while she actually continue to try to connect to the webinar. I hope everyone will stay calm, stay patient, and continue to stay with us until the end of the webinar.
Dr. Aston, I think that there's a few questions about non-MMA members, how for them to claim the CPD points.
Okay, I have to okay, for non-MA member, later I will show the QR code. If you are medical practitioner, you can actually use the MMA event applications and scan the QR code through the applications. So by right, after you scan the QR code, you will straight away get 3 MMA CPD points in the applications. Okay, for those non-medical practitioners, I'm sincerely apologize because we doesn't provide e-certificates for this webinar. But what you can do is you can either snapshot the webinar to prove that you are attending the webinar, or at the end of the event, usually after 1 day of the webinar, we will send out the post-event thank you email. You can actually use that as a proof of evidence as well. Okay.
I think that's clear.
Yeah. So we try to connect again with Catherine.
Okay, welcome back, Catherine. Please unmute.
Sorry.
Unmute. All right. Welcome back, Catherine. Yeah.
Welcome back, Catherine. Catherine, do you want me to share on behalf of you the content so that you can continue on your presentation?
Can you?
Yeah, so I will share your slide. So you just have to focus on
Dr. Elson, I get the slide.
pardon? Yeah, can you see the slide? Catherine, can you see the slide? Yeah, Catherine, can you see the slide? Okay.
We cannot hear you,
Yeah.
Catherine.
Okay. Can you see?
Okay, I'm so sorry about this. I'm not sure what happened. So with EMC, usually the severe muscle cramps actually happen in less than 1 or 1,000 out of 60 over 1,000 of runners.
So, do we stop here just now?
Yep, you stop here.
Okay, thanks. Good.
Can you, next? Yep, so the risk factor for EAMC is endurance sports and team sports, like what I said earlier. In American football players, it is said that most of the time cramps actually occur during hot weather. And also EMC is actually more common during the first 3 weeks of practice. After they have a long break, when they restart their training again, that's when the fitness and acclimatization levels are likely to be the lowest. And that is sometimes when the training load is the highest, depending on the coach. This is when they are more prone to getting EAMC. Next. Okay. So what I'd like you to note is that there are a lot of limitations to conducting research on EAMC because if you induce muscle fatigue based on different from muscle due to voluntary muscle contraction. Because if you induce the fatigue based on electrical stimulation, usually the larger diameter motor neurons are stimulated first, and actually it lasts with voluntary contraction. So that's why it is difficult to actually conduct research. You can actually put them in labs and on treadmills and get them to run and then put them on electrical stimulation, but you may not necessarily be able to induce cramps. The next thing to note is that muscle fatigue is actually a continuum rather
I'm feeding Anna, darling.
and absolute and the child. Okay, next. Next, Dr. Elson. Yeah. So what I was talking more on was actually EAMC, but you need to know, note of other medical conditions that can actually cause cramps. What you need to know is actually, can you go back to the rhabdomyolysis? So in rhabdomyolysis, the symptoms are slightly different, may actually cause cramps, but usually you will notice swelling, muscle soreness, and tenderness, and that usually happens after intense exercises. So in rhabdomyolysis, in severe cases, it is actually life-threatening and the person may actually need ICU care. So if they do go to the hospital, that's when the doctors will actually do order tests for their CK level, and you may actually test for their myoglobin in blood and urine. the potassium level, and the creatinine in blood and urine. If someone has a rhabdomyolysis, usually you notice that the urine color is this color. Next. So the differential diagnosis for this will also be hyponatremia. Hyponatremia is defined as when the sodium level is less than 135 millimoles. In severe cases, it's lesser than 125 millimoles. But with hyponatremia, in a true hyponatremia, generally it's more of a generalized skeletal muscle cramping. And hyponatremia can occur in sports events, especially if they only drink plain water when they are exercising in a prolonged period of time, like in a long distance marathon running. If they only drink plain water, that's when hyponatremia can happen. But if a true hyponatremia were to occur, usually the muscle cramps will be more generalized. Next. So how do you prevent hyponatremia in sports events? Generally, it's do not overdrink only plain water. And the next thing is, if it does happen, that's when you need to drink more of some salt, sports drinks and things like that. That will help, especially if it's exercise in a prolonged period of time. Okay, next. So next thing that can, another differential diagnosis that may actually cause muscle cramps will be hypoglycemia. So hypoglycemia is when the sugar level is actually lesser than 4 millimoles per liter. And it is usually accompanied with other symptoms as well. That is why as a sports physiotherapist, the team physiotherapist or the team doctor, the team medical professional, generally you need to know the medical history of your players so that you can actually manage that. And that's when you need your BGM monitor with you, especially if you know that you have players that you're covering that has diabetes. Next. The next thing would be dehydration. So with hypohydration is defined as water deficit of 2% or 3% of body water of the average athlete. So hypohydration usually happens more in when it's a hot weather, if it's more than 27 degrees, and it is shown that it actually impairs your aerobic performance. So for every 1 degree Celsius of skin temperature elevation, there is a potential loss of 1% of your aerobic performance. So with dehydration as well, usually it is more of a generalized muscle cramp. Okay, next. The next thing we need to know is your exertional heat illnesses, especially if you are the medical team that's covering events in hot countries like in Malaysia. Yeah, so we have things like a heat syncope, which actually causes dizziness, brief episode of fainting. You have a heat cramps, which is actually more generalized and it can be painful as well. But usually in this, the temperature, the skin, the body temperature may be elevated, but it's still lesser than 40 degrees. The next level is when you have heat exhaustion. And then the last is exertional heat stroke, which is life-threatening. This is when they need to go to the hospital and they need to go to the emergency as soon as possible. Next. So we'll just go through a few researchers that I can find because I actually scanned through ACSM, I scanned through BJSM, but there were not a lot of researchers. And a lot of the journals that I pulled out, they actually quoted the same few researchers. So in 1985, they tried to conduct studies on cramps that were initiated by EMG. So their conclusion was that passive stretching leads to a decrease in EMG, and the compression of pain site lowers the EMG activity. But my question to that research, when I read the research, was that there was actually no comparison and cramps would actually resolve spontaneously. So I don't think it's valid for them to say that passive stretching and compression alone will actually lead to reduction in cramps. And it was only a 4-case study. Next. The next thing is, this was a prospective cohort study conducted in 40 over 1,000 distant runners. So these are some of the risk factors that they pick out, and this was actually done based on survey. So if you look at it, the least generally shows you are at higher risk of getting EAMC if generally you are someone who fits the criteria of being less fit. Like if you run slower and you train lesser and you have just started training and whatnot. So this is when you're at higher risk of EAMC. What you also need to know is that if with increased age, there is also risk of getting cramps in general. Next. Okay, so the next one was more interesting because they actually did a study on Ironman triathletes, 210 of them. So they actually tested their pre and post race serum electrolyte concentration, and they showed that those who experience cramp and those who do not experience cramps do not show significant difference in their pre and post electrolyte concentrations. Next. So how do we prevent EAMC? The main aim to prevent EAMC is actually to prevent premature muscular fatigue. So if you have athletes who had an injury or just recently had an operation, that is when you need to ensure that your athletes actually completed the return to sports rehabilitation phase with the physiotherapist, because that is very important so that they do not put themselves at risk of getting EAMC. The next thing is periodization of training. So that is when the coaches will need to know when to increase the intensity and when to reduce the intensity based on when the sports events are. So acclimatization to hot environment is also another thing to note, and that will help to prevent premature muscular fatigue. Next. So to prevent that, generally your athletes need to be well conditioned for the activity. They need to ensure that they have flexibility. They need to have routine periodic stretching as part of their training. You also need well-balanced diet, electrolytes and carbs and whatnot. And if it were to happen, that's when you need to reduce the intensity and the duration of exercise. Next. So with the management, if EAMC were to happen, generally, if you know your athletes well, you know when to pull them out. So sometimes you need to withdraw them from the athletic activity on the first cramp because it's a sign of fatigue. And if you're playing team sports, then you do not want to be dead weight to your team. So if you're having cramps every now and then, you are a dead weight to the team, and that's not fair to your teammates. That's when the coach may actually pull you out. So then the next thing, what physios generally do will be more active and passive stretching, especially if EAMC were to happen. And these are other ways to actually help to manage that. But what I would like to pinpoint as a sports physiotherapist is that you need to conduct sport-specific training as part of your return to sports rehabilitation phase. Yep, can we go next? So if cramps were to happen during sports events and you are the team doctor or the event doctor or event physiotherapist or the medical practitioner, that's when you need to know how to manage cramps. So in a true EAMC, those will be things on the left. Usually with a true EAMC, there is no loss of GCS, mental state level is the same. That's probably just fatigue. And there's normal diuresis and normal body temperature. So if EAMC were to happen, that's when you need to offer on-site assistance, things like rest, oral rehydration, ensure that they're in comfortable environment, and passive stretching. And if there is severe cramps, which leads to consciousness alteration, when there's a drop of GCS, and generalized cramp, anuria, or myoglobinuria and whatnot, that's when the person needs to go for clinical assistant emergency. This is when they need to go to the emergency department as soon as possible because it could potentially be life-threatening. Next. So in the recurrent cases, if it keeps happening in an athlete, that's when we need to complete the medical history. We need to dig out what are some of the risk factors and what are some of the contributing factors of why this keeps happening. Then you need to rule out if the person actually has any medical condition as listed. So, yeah, next. So, with hydration, ACSM actually recommends 4 hours before the event to have half cup of fluid for every 40 pounds of body weight, which if you translate to kilograms, then it's about 5 to 7 milliliters per kilogram. And during event, especially if it's hot and humid, that's when ACSM actually recommends sports drinks, which has all these electrolytes. And then post-event, ACSM recommends 3 cups for every pound lost during exercise. But then again, unless you are a professional athlete, most of your recreational athletes do not actually weigh themselves pre and post exercise. So my general recommendation is that they should actually drink to replace the fluid loss. Next. So the next few slides is actually to talk about some of supplementation and some of the other things that I commonly use. So quinine is actually tonic water. Predominantly in the medical world, it's actually used to treat malaria. So many years ago, it used to be used to treat cramps of all causes. However, a Cochrane review showed that quinine may actually reduce muscle cramp frequency, intensity, and cramp days, but there's adverse risk of event for quinine. So in 2004, which is actually 17 years ago, the FDA actually withdrew approval for quinine for nocturnal muscle cramps because of the risk of thrombocytopenia, which is a low platelet count. Okay, next. I think this is a controversial thing as well, magnesium supplementation. If you actually look through researchers and medical journals and whatnot, there's no strong evidence to actually propose magnesium as a supplementation to help with cramps. So as far as I know and search through BJSM, ACSM, I can't really find journals and whatnot that strongly propose magnesium supplementation as a cure or prevention of cramps. And if it's true, so we do know that magnesium deficit can actually cause cramps, but you need to diagnose the person first. Unless it's proven that the person has magnesium deficit based on blood tests, I don't think it's actually necessary to actually supplement magnesium unless there's a reason behind it. Yeah. Okay, next. Salt tablet. Your athletes drink salt and whatnot. So that may help with more of dehydration or in events where you lose a lot of water through sweat or electrolytes. But that is more of heat cramps and generalized cramps, so it may not necessarily treat EAMC. However, because it doesn't target the cause of EAMC, which is your muscular fatigue, so salt tablet actually doesn't really help EAMC, but it may help with other sorts of cramps. Okay, next. So sports drinks. So sports drink itself doesn't necessarily help with EAMC, but with sports drink, it may actually help with dehydration and loss of fluid based on your exercise as well. What you need to note is that if you drink water, you need about 13 minutes for it to be absorbed in the circulatory system. So in cases where there is severe cramps or severe EAMC or whatever reason where it's severe, that's when you need an IV infusion of fluids. And this is usually done by the sports physician on site or the ED doctor on site. Yeah. Next. Next. Yeah. So, can you go one behind again? There. Yep. So generally, the American National Athletic Trainers Association recommends that athletes prone to muscle cramping to add some salt to their drinks, and that is assuming that there's a relationship between dehydration and EAMC. But in cases like what I said, if it's heat cramp and generalized cramp, then salt may actually help, especially if they exercise for a prolonged period of time. Next. Pickle is another controversial one. So if you look through research and whatnot, right, actually there's no, I can't find any strong evidence or any medical journals that strongly propose pickle as your treatment to prevent or to cure cramps. So in this study that was picked up that I could find, they said that because it is such small volume of people, it is unlikely to change your electrolytes and body fluid chemistry so quickly. So it was claimed that when somebody takes some pickle, it can actually relieve cramps in 35 seconds. But this is based on a case report and standard doctor evidence, which is level 4. But it's speculated that pickle juice may trigger a reflex, which may increase your inhibitory neurotransmitter activity in your cramping muscles. So that is what is speculated, but I can't find any journals that strongly propose this. And you also need to note that in this research that I've spoken about, it was actually the cramps were actually induced by electrical stimulation rather than voluntary exercises. Okay, next. You'll be surprised that there are claims out there that say that chili peppers, your wasabi, or even ginger may potentially help with cramps, but I can't really find any research or journals that actually strongly propose it. So we're not too sure how it's supposed to work, but one of the proponents for it is that some of these channels are stimulated by the active component of your spicy food, because when we eat spicy food, capsaicin and whatnot, we do get sweat and whatnot. So I'm not sure how that's supposed to work, but some do claim it. But from what I find, I can't really find anything that actually strongly proposed for it. Okay, next. So I've gone through with you the EAMC and other differential diagnoses like heat cramps, exertional heat stroke, and whatnot. So this is when, based on my experience, I'll just be sharing some case studies that I've gone through as a sports physiotherapist when I covered different sports events. And as a sports physiotherapist, the action out there is what excites me. So I'm just going to show you some photos and whatnot. Okay, next. Okay, so the first one, it's more of when I was in Australia. So what I'm trying to pinpoint here is you need to know your demographics of those who is on the field. So I covered the Aussie rules football. If some of you are familiar with, it's almost like rugby, but it's not exactly rugby as well. Guess who is more prone to getting EAMC? It's actually not the players, it's actually the referee. Because referees are generally of older age and they may not go for training, so their fitness level may not be as good as the typical players. And with Aussies, they love drinking, so they drink after sports and they don't do their cool down and whatnot sometimes. So this puts them at risk of getting EAMC. Yeah. The one in pink, it's actually me with the football club. So next. So that's more of EAMC. So based on this, it's more of EAMC. Next. This one is when I covered Maybank Championship. It's actually a big event. It's actually a co-sanction between Asian Tour and European Tour with a prize money of 3 million USD. So there was one player that flew in from Europe, an European Tour player. He flew in from Europe. Within the first day of play, he had to pull out. Guess what? It's because of his caddy. His caddy had hit syncope. And as a professional golf player, if you have no caddy, that affects your performance as well. And he had to pull out. So he was experiencing some heat cramps as well. But because his caddy that he flew together with had hit syncope, that's when so he had to pull out because of that. So imagine how devastating it is to this player, because he will need to explain to his sponsor why he couldn't participate in this event. And that's when all these golfers will actually come to the medical professionals for us to actually sign to clear them that they had to withdraw because of medical condition. So it is quite sad that it happens. They had to pull out from sports because of cramps. And it's a 3 million USD prize money event. Yeah. Next. Another event that I remember vividly was it happened in Sarawak when I was a physiotherapist for the event. There was an Australian golf player who flew into Malaysia, and obviously is not used to the hot weather over here. that's when he had to withdraw because he started having these heat cramps and whatnot. And I remember I had to like sort of like babysit him every 1 hour or every half an hour. I had to like text him to ensure that he's doing well, because if not, then that's when I need to highlight to the ED doctors and whatnot who were taking care of them. So these are just some of the photos that I had from my golf events overseas. Yeah, so this is Justin Rose. If you're a golfer, you will actually know him because he's an Olympic gold medalist. Next. So in golf events, I've seen heat syncope. I've seen EAMC. I've seen heat cramps. I've also seen heat exhaustion. So it's all different. That's when you need to know how to actually manage all these different ones. Next. The next one is actually a case study that I wanted to show you guys. Maybe Dr. Elson, you can see if you can click on it. Yeah, you can click on the link. I'm not sure whether it works. But okay, if you can't, it's fine. Just wanted to show that a player was down because of a acute ankle sprain and also muscle cramp, and I had to run in. That was when I was still working in Singapore, so I was actually covering the Asian Para Games football 5-a-side for the visually impaired football. I was with the Singapore team. So it's quite interesting because you will see me running in and then followed by the other team members. Okay, next. It's okay if you can't play the YouTube link, we can just skip that. Dr. Elson, next. Maybe you can just stop that, it's okay. Yeah, can we go next? Dr. Elson, I think we can just skip that, that's okay. That's good. It's okay, we'll just skip that.
Aston, we just move to next slide, Aston.
Yeah, we just go to the next slide, yeah.
Yeah.
Dr. Elston, can we go to the next slide?
Next slide, okay.
Yeah, we just skip this YouTube, it's fine. Yeah. Next time then. Can you play the next slide?
Sorry.
No, just stop this. Yeah. So just show back the slides again.
Okay.
Yep. I just wanted to show a case of EMC where it was actually caught live on TV, where it just shows that you need to know how to manage, because you're on live TV and you cannot do things that are not right. So this is from the event. So these are just some of the photos. I had a photo with Lee Hsien Loong, the Prime Minister of Singapore. Next. The next case is when I covered Audi World Cup speed skating. If some of you are familiar with what speed skating is, if not, you can actually just Google or YouTube what speed skating is. It's actually a winter sport, and this was held in Shanghai, so it was quite cold. So I was wearing my thick jacket, and in this case, I was covering an athlete, and because it's quite it's very high intensive sport where depending on the event, whether it's a short or long haul event, it is actually quite taxing for the muscles. So in this case, it was more of a cramp prone state because I had to do my sports physiotherapy stuff after the event itself. All right, next. And next, the last one. The last one happened when I was in Singapore. So I was one of the physio that covered the event. This was a Standard Chartered marathon in Singapore. Next. I still remember that it was a male, a Caucasian, who was quite young. So he presented to our medical tent for cramps, and he was assisted by a volunteer inside. When he came in, his GCS was at 14. But actually, sorry, just because this slide was not updated, but within 2 to 3 minutes, that's when his GCS dropped, and he was sent to the hospital through ambulance. Can you press next? In this case, it was more of an exertional heat stroke. Can you press next? Because 1 to 2 days after the event, I remember I read in the news that the guy was admitted to the ICU in Changi General Hospital, so it must have been a pretty serious condition to be admitted in ICU. Yep. So with all these different case studies, right, it just shows that you need to know when it's time you actually highlight to bring to the next level of medical attention, or when it is that you can actually manage it on your own. So you need to know what is your professional boundary, and when is the time they need to go to the hospital. Okay, next. So just a recap, when there's acute severe muscle cramps, next. That's when usually it's accompanied with drop with GCS, generalized cramp, temperature alteration, the anuria, myoglobinuria, then you need to send the person to emergency. And usually the bigger sports events there. Yep. So conclusion, EAMC is unpredictable. That's why it's very difficult to conduct research. And EAMC usually it resolves spontaneously. If it does happen, it can be a variable in the intensity and duration. Next. Dr. Elson.
Yeah, can you see the slide? It's already,
yep.
Yeah.
Usually it's okay, but if it's other medical condition, that's when you need to know when you need to send the person to the hospital. So EAMC per se may not be life-threatening, but repeated event is career-threatening. So imagine you're a golfer who's fighting for a 3 million USD prize money, but you have to pull out because of it. If it keeps happening to the golfer, I'm sure he'll have difficulty to explain to his sponsors, and that could potentially be career-threatening as well. So that's just for us to note. That's why as the medical professionals on site, we need to know how to manage all this. Yep. I think the next stage is actually more of just Q&A.
Okay, thank you, Catherine, for the very wonderful and fantastic. It's all about muscle cramp in sports. It's common but can lead to fatal condition. We can entertain few questions here. Question from K. Chung. May I know if 100 plus or Revive isotonic drinks considered a sports drink? And if not, what example of proper sport drinks? You want to answer now? Catherine?
Yep.
Hiya. Catherine, you want to answer first question?
Do you have the slide for the questions? Because I can't see the slide.
Just click at the Q&A part, Q&A box.
Yep. That's fine. I can answer that now. But you have the slide. No, you don't have slides. Okay, that's fine.
We don't have slides.
I don't know. There are many sports drinks out there, and I'm not a sports nutritionist, not a sports dietitian. Okay, can you hear me? I'm so sorry. I'm not sure what happened to that today.
Not smooth.
Yeah, so there are a variety of not smooth. Do you want me to just answer on the chat box?
You want to go to second questions?
Yeah. Okay.
Yeah, there. The questions we are putting out on slide already.
So usually these are the commercial ones, the 100 plus, Revive. I'm sure there are a lot of brands that I can't just think of right now, because in different countries they use different sports drinks. So when I was in Australia, it was my first time in Australia. I went to ask 100 plus. They had no 100 plus, and they gave me a blank stare. What is 100 plus? So there's no such thing there. So in different countries, they have different isotonic drinks. So usually those are the ones that athletes prefer because it has some sweet taste and whatnot. But some of the other proper sports drinks and whatnot, sometimes it's actually more of the sachet that actually athletes and the coaches or the team, medical team actually bring along that will contain electrolytes and whatnot, and that will help as well. Yeah. So I don't really know the brand, so it really depends on which country you are in available. Okay. So we just make use with what we have. Yeah. Should I go to the next one?
Okay. Second question: in risk of second cramp after the first cramp resolves.
Yeah. And, so the second question is, let me just have a look. Yeah, resolve and stretch. So it really depends. So like what I said earlier on. So it really depends. Usually, as a sports physiotherapist, if there's a first cramp, if they are out of field, I usually do not suggest them to go back on field based on the quarter itself. So I will actually monitor them. If they are all fine and you do their stretching and warm up again, if especially in cold weathers, I think it's potentially okay, but you need to know your athletes well before you can suggest, because some athletes are more prone to getting cramps. So if you're not too sure on what's the history of this athlete, then you need to ask for more medical history and whatnot of whether they have cramps and whatnot. But usually if there's a sign of first cramp, it just means that they are already facing fatigue. So it depends on, you need to check and balance as well, because you need to know whether this player is a star player, like he must be on field, or he's probably someone who is important but not so important as your other star players. So that's when you need to check and balance to see whether you should suggest that they need to fill in or not. So that's when you need to have a good relationship with the coach to discuss and see whether this person should go back to sports or not. So if this person is a star player, maybe I'll just do the management and then I'll leave it to the coach to decide whether to go back in. Same as if someone is not like a star player, and if he already has a first cramp, usually I'll suggest that you get another person to substitute this person. Yeah.
So okay, I think okay, we go to last question. Challenges in high altitude training, muscle cramps.
Dr. Rumani, do you want to go through, or do I just answer the question?
Just answer, yeah.
Yeah, okay. So with the third one, I think it'll be quite interesting to answer this because I don't really know the answer to this. Cramps can still happen in high altitude training, that's for sure. And it depends on who's on site. I've not personally covered any high altitude sports events, so I don't really know what is the incidence rate like. But I would say that if it's in a cold place, generally it's very difficult to get them to warm their muscles sufficiently. That's why in a cold place, high altitude is usually associated with colder place. That's when you need to ensure that they warm up maybe really like a good 10-15 minutes before they were to be fielded in again. So if a player is substituted out and if he's going to go in again, that's when I will ensure that they actually do their warm up while waiting. Yeah, so that they do not cool down. And because if you cool down, then obviously you're getting risk of injury and put your muscle at risk of fatigue and whatnot as well. So potentially that could be it. Yep. Do we have any other questions?
I think that's about it. We have reached end of the session. I would like to thank again all three speakers today, Dr. Apara, Dr. Rizmi, and Miss Catherine, for the wonderful talk and presentation. Hope we have gained knowledge and an eye-opening to us in handling the sport emergencies if it happen when we do covering games in whatever situation. Okay, can we give a big applause to ourselves? Okay, I just want to remind we have another series of a sport emergency webinar next week. The topic will be interesting as well. It's about eye emergencies in sports, sport concussion in rugby, and also high altitude emergencies. So don't forget to join us again next week. I think that's about it. I pass back to our host, Dr. Elston.
Okay, thanks so much, Dr. Ramani, for moderating this wonderful webinar. Again, I want to thank all the distinguished guest speakers for the wonderful and delightful talks. I'm sure the audience already gained many informations and widen their our knowledge about what is being discussed today. And also, I like to take this opportunity to thank all the audience for the active participations and also asking the questions to the speaker. Okay, so before we end, I would really appreciate if the audience can actually help us to fill in the feedback form, okay, by scanning the QR code, or you can type bit.ly/sports feedback 2, or you can actually fill out the feedback form through the email that we will send to you after the event. We really appreciate your constructive feedback so that we can improve our event better. Okay, I'm very sorry if there is any shortcoming because of the lagging of the internet, the connections, but this is usually happen, especially in Malaysia. Okay, so see you next week for the third series of the webinar, which is we have another 3 very interesting speaker, but the time is at 9:30 a.m. So don't miss our last series of webinar next week. And before we end, I would like to share the the QR code for the MMA CPD event. Please, this is for the medical practitioner. You can actually scan the QR code by using the MMA event applications, and you will get 3 CPD points. Okay, if there is any questions or any suggestion, any query, I actually encourage you to email to us and anytime by writing to us at secretariats@malaysiansportmed.org. Okay, thank you so much and have a wonderful weekend. And I hope you really enjoy the webinar that we actually brought to you today. Thank you so much and goodbye.